hypoglycemia is a very, very common presentation in terms of clinical practice, especially in the neonatal period and the post-neonatal period. And there are a lot of implications in terms of the pathophysiology of understanding, because that decides about your etiology as well as information about how do we approach and how do we evaluate in terms of investigation. So we'll be spending quite some time in terms of pathophysiology, and then we will move towards the phenomena as to what are the causes and how do we evaluate from there. So from a pathophysiological perspective, what are the key ensures which maintain the blood sugar levels in the body?
First is a regular intake of source of glucose. The second is in stages of fasting where you need your hepatic glycogen crisis to keep. So glucose storage disorder, glycogen storage disorder.
So first, of course, is the food intake that you take. The second step, which will prevent hypoglycemia, will be glycogenolysis, then gluconeogenesis, and then the fatty acid oxidation defect, which will be there. Now, simultaneously, while you are activating these processes, you will also need to inhibit some of those processes. So which processes will be inhibited if you are fasting? Glycogenolysis will be increased. So glycogenesis will be impaired, your lipogenesis will be impaired. So you're basically going towards a catabolic mode. So all you need to understand is what are the things which increase the blood sugar. If your sugar levels are low, those levels will go up in that perspective. In terms of hormonal regulation, we always talk about that we have got insulin, which is a prime regulator of acting against hyperglycemia. And we have got 4 ones which are acting as a counter-regulatory hormones in that perspective. So if you are developing hypoglycemia, which of these mechanisms you would like to start first? Okay, what else should happen? So if you got less money, what would you like to do? Would you like to stop your spending first, or would you like to get more money, borrow more money from there?
Stop spending first.
So insulin inhibition of insulin will be something which will happen at a very early stage, and that's what we discuss about. So epinephrine, yes, and there are variabilities also as to what level it acts and other factors, but the first cardinal event will be suppression of insulin. So we'll discuss about what levels insulin comes on, but as soon as your sugars are low, the first thing will be to decrease insulin so that you do not waste your sugars. And then you will, of course, have the counter-regulatory hormones from that perspective. Now, insulin, of course, is very important because hyperinsulinism is the most common cause of chronic hypoglycemia. So we need to understand about insulin. Insulin is produced via the insulin gene, and we know that it's produced as a pre-pro compound. So you have pre-proinsulin to proinsulin to insulin, which is converted via the pro-convertase enzyme. Now, insulin has got 2 chains, A chain and B chain, which are linked via the bonds in that perspective. Now, there are specific promoters which act in this pathway: HNF1 alpha, PDX1, NeuroD1, and HNF4 alpha. Now, these are more important when we discuss in terms of the monogenic forms of diabetes. But what is the relevance of HNF1 alpha and 4 alpha from hypoglycemia perspective? Yes, so this is very, very important. So there is some problem in signaling. Initially, you may have macrosomia, hyperinsulinism, and you have hypoglycemia. And then in around adolescence or later in life, you will develop hyperglycemia, which is there, especially for HNF1 alpha and 4 alpha, which is important. HNF1 beta, we already discussed, is involved in terms of renal cyst and renal formation as well. And they have an interactive process. Now, insulin secretion is intrinsically linked to the level of glucose in the body. But rather than sensing insulin, rather than sensing glucose, the beta cell sense what? What is the most important final regulator of your insulin secretion? Is the energy status. So how much is the energy? So it doesn't matter whether this energy is coming from glucose, whether it's coming from fat, whether it is coming from the proteins. It doesn't matter to it. If your ATP is high, you will produce insulin. Now, how does this happen? So you have got the various processes as discussed. HNF4 alpha, 1 alpha are the promoters. you've got the potassium channels which are there, and you have got the insulin which is already preformed. Now, insulin is a large compound, you cannot produce immediately, so you produce it and keep it in the vesicles. Now, what happens basically is that whenever your potassium basically, your channels close in that perspective, your potassium levels will accumulate. And when your potassium levels accumulate, this will be depolarization of the membrane. Calcium will enter into the cell, and this calcium will result in a insulin secretion. So closure of this potassium channel is going to cause hyperinsulinism. So which drug will be effective in treating it? You want to? So this will be a potassium channel opener. So that is how it will be working in that perspective. So insulin secretion is there. Now, how do we link the nutritional status to this insulin secretion is something which we'll discuss. So nutrients, you may have glucose which enters via GLUT2, and then you have got a very, very specific form of enzyme which is glucokinase. Now, every cell which has, if you remember the glycolytic pathway, you will say hexokinase. But pancreas has got specifically a glucokinase. Glucokinase and GLUT2 act as a sensor of your levels of glucose. Higher the GCK activity, higher the glucose level. Glucose getting converted into ATP. More ATP means more insulin. So more GCK activity will cause hypoglycemia. Less GCK activity will cause hyperglycemia or MODY type 1, which we have discussed in detail. So this produces glucose 6-phosphate, which produces ATP. Now, this ATP is also, there are multiple areas which will be there. So you've got the MCT1, which is there in the mitochondria, which is responsible for that. ATP will also come from the amino acid pathway, which is the GDH, the glutamate dehydrogenase pathway, and the fatty acid pathway, which is the SCAD pathway. So increased amount of glucose, increased amount of amino acids, increased amount of fatty acids, activity in terms of GCK, GDH, and SCAD will all result in increased level of ATP. Increased level of ATP will cause more insulin secretion, and you will have hypoglycemia in that regard. So this ATP goes up, you got an uncoupling protein, and from there this ATP will really cause this closure of the potassium ATP channel. So if you remember one thing, that ATP is determined via the glucose, via the protein, via the fat pathway, and this ATP regulates the potassium channel. You will be much clearer about how do we have regulation as far as the insulin secretion is concerned in this perspective, and this becomes important. Now, the fact that if you have got more level of some amino acids like leucine in individuals who have got activating GDH mutation, if you take a lot of these leucine, what will happen, Vani? You will have hypoglycemia, because if you take more of it, you will have more insulin secretion. This is known as protein sensitive or leucine sensitive hypoglycemia, which is a classical feature of GDH. What is the other important feature of glutamate dehydrogenase gene defect, which you can identify on a simple laboratory test? So high ammonia, hyperinsulinism, HeHa syndrome, along with what was earlier known as leucine sensitive hypoglycemia in that perspective. So this is how you will have. There are other regulators of insulin secretion as well. So you've got beta and alpha, epinephrine and alpha. So they will have different regulatory pathway which are antagonistic in that perspective. You've got somatostatin, which will inhibit the insulin secretion, making it the drug of choice in any form of hyperinsulinism. You've got incretin, growth hormone, estrogen and cortisol. They all increase the glucose, the insulin production. So incretin, we all know, is very, very important from the diabetes perspective as well. Now, in the insulin process, you have got the first phase, which is the initial preformed insulin, which is released, and then the second phase is the new synthesis. So most insulin that you secrete is already preformed, and therein this potassium ATP channel will be doing a work. Now, how does insulin work? What is the type of receptor of insulin? Tyrosine kinase. Okay. So basically, you have got what are the different types of receptors? Growth hormone is which one? Huh? Jack said is the pathway, but what are this thing? And this is also tyrosine kinase. This is type 1 cytokine receptor. So insulin, IGF-1, they are all type 1 cytokine receptors. So what they have, they've got an alpha chain and a beta chain. So when you say a JAK stat, so they've got the JAK associated. Here you have got this activity which is there. Now once insulin binds at the low affinity and the high affinity, there is a negative cooperation. If insulin is already binding, they will then switch over together, and this will result in bringing closure, and you will have the activating pathway which is there. You will have the phosphorylation, and this will then activate the subsequent mechanism. So you have got insulin related substrates 1 and 2, which will then activate the PI3 kinase, which will result in the entry of glucose, which will happen into the cell, predominantly from the insulin dependent GLUT from there. There is also the second pathway which activates the MAP kinase, which causes cellular growth and mitogenesis. So insulin and IGF-1, they are pretty similar. Insulin, however, is mainly regulating glucose, while IGF is mainly regulating growth. There is some cross reactivity. Insulin can act on the type 1 IGF receptor. Insulin itself can cause growth, and therefore, if you have anybody who has got hyperinsulinism from the fetal period will have macrosomia as a possibility. Now, importantly here, what you are seeing is that the insulin action is very, very important in activating the GLUT4 in that pathway. Now, what does insulin do? It will, of course, have all the things to decrease the glucose level. It will increase the production of glycogen. It will decrease the glycogenolytic pathway. It will inhibit the gluconeogenic pathway. It will inhibit the ketogenic pathway. So it's all an anabolic hormone from that regards. To counter that, you of course have got the counter-regulatory hormone. You've got growth hormone whose major effect is at the level of lipolysis. Now there is overlap, but you can remember which one is working where predominantly. Growth hormone predominantly work as a ketone production lipolysis. Cortisol, its main effect is at the gluconeogenic pathway. You have got epinephrine, which is acting at the glycogenolytic pathway largely, as well as the lipolytic pathway. And then you have got the glucagon, which is a major, which I've already discussed, is a major regulator of the glycogenolysis pathway. So this is how it works in that regards. So if you look at the various activities, insulin is going to inhibit everything. Glycogenolysis is largely stimulated via epinephrine and glucagon. Gluconeogenesis predominantly via cortisol, a bit also via glucagon. Lipolysis predominantly using growth hormone and epinephrine. And you have got the epinephrine and glucagon, which will act as the ketogenic pathway as well. And insulin also will inhibit the entire pathway. So we have till now discussed about what are the various hormonal mechanisms. But as I said, the first immediate mechanism of this is the gastric regulation. So if your sugars are going low, you will start eating. That will be the first mechanism. So how do we have this gastric mechanism? In the setting of when you are not eating, your distension of the stomach becomes less. And your distension becomes less, you secrete ghrelin. And ghrelin acts at the ventromedial hypothalamus to say, okay, I want to eat more. It will also go at the ghrelin is what? It's a, well, how do you get the name ghrelin? Ghrelin is an acronym for GH-relin. So it's a growth hormone releasing peptide. So it was identified as a growth hormone releasing peptide. But remember, if you are hungry, first thing you will say, you want to eat more. So you go to the hypothalamus, then you tell the growth hormone that, okay, now you start doing all the lipolysis process. You will have more production of ACTH. And then it will also going to act on the adrenal. So it will increase the cortisol and epinephrine and all those pathways. So if you are hungry, you will be more stressed or less stressed. So you will produce more cortisol. So both hunger and too much eating, both will result in hypercortisolism. So this is the mechanism. Now, this was more for when you are less. What will happen if you have eaten in that perspective? Now, Dhwani, if you do a test, you've got two groups of people. In one group of people, you give intravenous glucose. The other group, you give oral glucose, and pharmacokinetic, you know that this is equivalent. So you say, okay, this is equivalent in terms of that. Who will have a lower level of 2R value? Those who have been given the intravenous or the oral ones? So that is very important. So this is how, when we talk about insulin and everything, in fact, Beth had predicted the presence of incretins at that time. So they did this study, IV glucose tolerance versus oral glucose tolerance. You will find a difference. In oral, you will have a dip. Many patients, 20% patients will come to you and say, this report hi galat hai. This report is wrong. Ki fasting is more and PP is less. But 20% people, if you look at normally, may have a lower level of 2R value than the fasting value because of the incretin response. So now, Alapan, you say that why does the insulin secretion happen? Would you prefer that once your blood sugar increases and then insulin gets secreted? How will that work? Suppose you have eaten, your blood sugar increases and now your insulin increases. Is it a good mechanism? If you wait for that time, what will happen? Your glucose will increase more. So your body wants a mechanism. As soon as you have taken a carbohydrate, you need to produce something to tell pancreas, okay, start producing or releasing insulin. And that's what the mechanism is, the incretin pathway. So essentially, when your carbohydrate reaches the intestine, you start producing GLP-1. If you have taken food, what all would you like the brain to do or the body to do? So you have taken now glucose, you don't want more entry of glucose. What are the mechanisms you would like to do? So you want to have more satiety. Second,
increase the blood glucose, the amount of glucose from the blood.
how would you increase? You want to increase the satiety. You want to decrease the release of that glucose into the circulation by delaying the gastric emptying. Third, good. Then fourth, when you're increasing insulin, you want to decrease glucagon. So incretin again. So as I said, ghrelin is doing multiple things. It's going to the brain telling, okay, eat more, producing more growth hormone, producing more ACTH, producing more cortisol, producing more epinephrine. Same as once you have eaten, okay, I don't want to have this long loop. So you have got low, high, all those sugar. Immediately, you will say, okay, now the gastric emptying should come down. So the food is released slowly. You will not have a rapid spike, which is going to happen. Go to the brain, tell, okay, you have eaten, don't want to eat more, stop, because otherwise, by the time your glucose goes up, you stop eating, you've eaten a lot by that time. And that is why it's very important that you do not watch television while eating. Because if you're watching television and other things, these signals may not be as effective. So this is the mechanism that your mind should be concentrated in eating. And that's why you will realize that, okay, now you are full even before you have eaten a lot. Now, this GLP-1 will, of course, go to the pancreas. It will increase insulin and decrease glucagon. So, in carbohydrate intake will increase your insulin, decrease your glucagon, decrease your appetite, and increase your delay your gastric emptying. And that is why the GLP-1 receptor analogs, be it oral or injectables, are used for treating diabetes. They will cause early satiety. You will eat less, so you'll lose weight. You will have a gastric emptying issue, so stomach will become bloated.